Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. In today's video, we're in session number 2 of our new series entitled The Instability Syndromes and the AMA Guides. Instability Syndromes and the AMA Guides. And in this program, we are dissecting the AMA Guides in chapters 15, 16, and 17 to pull out the permanent impairment ratings that are dedicated and reserved exclusively for instability syndromes. So we have spinal instability impairments, we have instability impairments of the upper extremity articulations, and we have instability impairments for the lower extremity articulations. And in session 1 of this program, we reviewed the shoulder instabilities. And before we go on to today's material on elbow instabilities, let's just reiterate the take-home message from the discussion on shoulder instabilities. Now, it's very, very interesting because the AMA guides and many additional outside references in the literature both describe some requirements for the examinee to qualify or to be classified as having an instability syndrome. So this message is reiterated several times throughout the AMA guides, and that is that the examinee must have both, number one, signs and symptoms, must have subjective complaints consistent with instability, such as a feeling that the joint is slipping or is going to go out of place, or is going to come out of socket, or is going to pop out, or some lay language similar to the foregoing. A feeling that the shoulder is going to come out of place, or other such similar words. So that's the first component. Additionally, the examinee must have true positive objective findings on provocative testing, which has as its purpose to assess for either subluxation or dislocation of the shoulder joint. So both subluxation and dislocation of the shoulder joint qualify as instability. And so the physical examination provocative maneuvers, such as the apprehension test, such as the loading anterior and posterior test, such as the sulcus sign or sulcus test, these provocative maneuvers must reproduce the examinee's apprehension that the joint is going to either sublux or come out of place. So both of those are required. The subjective component and the objective physical exam component, both must be consistent with instability. And when both are consistent with instability, then that qualifies as a true instability. And the AMA guides are consistent in their text under the shoulder instability section that both aspects must be present in order for the examinee to qualify for an impairment rating for instability. Absent one or the other of the components, the examinee is classified only as having a hyperlaxity syndrome. And a hyperlaxity syndrome does not qualify for a permanent impairment rating. Only a true instability qualifies for a permanent impairment rating. Thus, both components must be present. Well, I said it was interesting, and it is interesting because later in the table in the AMA guides, which provides for permanent impairment for shoulder instabilities, describes 3 types of instabilities: the occult instabilities, the subluxing instabilities, and the dislocating instabilities. And herein, in my opinion, the AMA guides contradicts itself. Because according to some new studies, which I've included in your references for this program, some new studies have dropped the term the occult instabilities and have removed the so-called occult or subtle instabilities from the classification scheme of the instabilities in general. Now, new literature is talking about only 2 classifications of instability: the subluxing instability and the dislocating instability. Well, so the AMA guides provide an impairment rating for what they refer to as occult instability. And in the description of the occult instability in the AMA guides dissociate the subjective and the objective components of the description or classification of instability and simply require only one or the other. In fact, they describe this examinee as qualifying for an occult instability when there's no history of trauma. There's no history of trauma to the shoulder, whereas the other instabilities require a history of trauma. They say in the AMA guides that in the occult instabilities, the physical examination maneuvers may or may not reproduce the examinee's apprehension of a subluxation or dislocation. And further, there does not even have to be a demonstrable etiologic lesion to explain the examinee's either subjective complaints that he has a feeling that his shoulder is going to pop out of place. So there does not have to be the presence of true positive objective findings. So here, the AMA guides, in providing impairment for the occult instabilities, basically provides a permanent impairment rating for an examinee who simply has shoulder pain and shoulder symptoms and equivocal to no physical exam findings, equivocal to no etiologic lesion to explain the cause of the symptoms, and little to no mechanism of injury. So this could be an additional permanent impairment rating that you could utilize with your very next shoulder pain patient, is the so-called occult instability impairment rating. So I encourage you to take a close look at shoulder instabilities and incorporate the shoulder instability examination into your shoulder exam protocol and become proficient in the shoulder instability examination. So when you have a shoulder pain case, a shoulder case, part of your routine physical examination procedure is to assess for instability. Assess for instability. We don't need a procedure to assess for impingement syndrome because impingement syndrome is not one of the impairments. There is no specific permanent impairment for impingement syndrome, but there is specific permanent impairment for shoulder instability, and the occult instability describes many examinees who could otherwise have what you previously determined to be impingement syndrome. Okay? So your exam needs to include an instability exam, even more so than it needs an impingement syndrome type of exam. Okay, so I found that to be very fascinating, and I hope you find it useful in your very next shoulder pain case. Now, in today's discussion, we're going to go into the elbow instabilities. And elbow instabilities, I'm going to admit to you, are going to be rarer. You're going to encounter them in rarer circumstances than you do shoulder instability cases. But still, any examinee who's exposed to repetitive elbow motions can loosen up and destabilize the anatomic restraints of the elbow. Any examinee who's fallen onto an outstretched arm or an outstretched hand can be left with sequelae of elbow instability. So the point is that these elbow instability cases are probably present in about as many cases as you make it a point to attempt to identify. So in other words, you will never identify elbow instability cases if you don't make a determined effort and a deliberate effort to include the instability evaluation in your routine physical examination for the elbow. And this is a principle that I've talked about in other discussions. And the principle has to do with the formulation and organization of your physical examination for examining injured workers. In examining injured workers, your physical examination procedures, maneuvers, tests, and sequences that you do need to have as their purpose. The purpose of those procedures is to identify or disprove the presence of impairments, is to identify the presence or the absence of impairments. You see, elbow instability is one of the impairments described in the AMA guides. Lateral epicondylitis is not an impairment described by the AMA guides. Instability of the elbow, however, is. And so therefore your physical examination should have as its purpose to identify the presence or absence of instability. So you need to have a fabulous elbow instability exam in your routine elbow protocol. Now, what you do in your clinical practice may be different, but in your workers' compensation permanent impairment evaluation, your elbow examination has to include an elbow stability examination so that you can tell the readers of the report whether or not that examinee either had an impairment due to elbow instability or did not have impairment due to elbow instability. And in today's discussion, we're going to review the elbow stability examination. But before we do that, we're going to go into some anatomy review of the elbow and the stability restraints of the elbow. And then we'll talk about the physical examination of the elbow for the stability assessment. And then we'll talk about what the AMA guys have to say for permanent impairment ratings for these elbow instability cases. Okay, so with no further ado, let's begin today's discussion on the elbow instabilities. Okay, so let's begin with some anatomic review of the structures that go into making up the elbow. And the purpose of this anatomy review is to demonstrate to you the contributors to both medial, lateral, and rotatory stability in the elbow. So we're going to take a look at the elbow from the perspective of how the anatomic features, structures, and landmarks in the elbow either contribute to or compromise the stability of the elbow. Okay? And so let's begin here with the distal humerus. As the distal humerus approaches the elbow, let's talk about the distal humerus. So the distal humerus is composed of two articulations, the trochlea and the capitellum. So here is the trochlea, which is a spool-shaped structure. And then here on the anterior aspect, this is the posterior aspect of the elbow here. This is the anterior aspect of the elbow, or the distal humerus here. So on the anterior aspect of the humerus, in addition to the capitellum here, in addition to the trochlea here, we have the capitellum here. And these are all projections and landmarks on the distal humerus. This over here would be the lateral epicondyle. This here would be the medial epicondyle. And then from the anterior aspect, this would be the medial epicondyle here, and this would be the lateral epicondyle here. Now, not seen in the anterior view is the capitellum, which is shown here on the posterior view. On the anterior view, the capitellum would be somewhat located on the posterior aspect of the lateral epicondyle. So this is an important landmark area, and this is some important real estate where we're going to see some heavy ligamentous traffic, which contributes to the stability of the lateral aspect of the elbow. Okay, so we have those landmarks on the distal humerus. Here, we're going to bring in the radius and the ulna bones. So this is an anterior view of the right elbow. This is lateral here. This is medial here. Okay, so we have here the ulna and the radius. The proximal ulna contains two articulations, which is the greater and lesser sigmoid notches. So right here, this is the greater sigmoid notch for articulation with the distal humerus here. This is the lesser sigmoid notch here for articulation with the radial head here. Okay, and those are both anatomic landmarks of the ulna bone. Okay, and you can see that the shape of the greater sigmoid notch is going to confer much in the way of stability of the elbow articulation, both by virtue of this lip on the anterior aspect. This is known as the coronoid process. Also by the slope and shape of the sigmoid notch, and then also the slope and shape of the trochlea. These factors contribute to stabilize this joint in rotation and also in varistretch stress, which would cause sliding this way. Because of the shapes of these opposing surfaces here, it makes it difficult for this articulation here to undergo rotational forces. Okay, the trochlea of the distal humerus and the greater sigmoid notch of the ulna bone have highly congruent anatomy with nearly 180 degrees of articular contact during elbow range of motion. So this articular contact here makes this a very stable articulation because of the large surface area of contact with opposing bones. And if we look at another view of the ulna, not seen on this view, but in a lateral view of the ulna, you can see that the olecranon process in the back of the ulna, together with this joint cavity here, together with the coronoid process here, do indeed create approximately a linear straight line, 180 degrees of articular stabilizing contact between these opposing joint surfaces. The lesser sigmoid notch articulates with the margin of the radial head at the proximal radio-ulnar joint. So this is the proximal radio-ulnar joint here. And then obviously the distal radio-ulnar joint is down at the wrist. Finally, the radial head articulates with both the capitellum here of the greater of the humerus and also the lesser sigmoid notch here of the ulna bone. So these are both areas where instabilities can manifest at the radiocapitellar joint here and then also at the proximal radio-ulnar joint here. So these all represents areas of potential instabilities of the elbow. Okay, so here we have a lateral view of the proximal ulna. And with the olecranon in the back and the coronoid process in the front, you can see that that creates an almost linear 180 degrees of articular contact here between the trochlea of the ulna of the distal humerus and here the trochlear notch of the proximal ulna. In addition to that joint surface, we have also the joint surface for the radio-ulnar articulation. And then another important bony landmark here behind the articulation here, just below what would be the medial epicondyle of the humerus here, is a landmark on the distal ulna, and that would be right over in this area here. This area here along this ridge and terminating right out here, this is referred to as the sublime tubercle. The sublime tubercle, and we're going to see that the sublime tubercle here is an area of attachment of most of all of the different fibers of the medial collateral ligament. So another potential area for instability would be here on the posterolateral aspect of the proximal ulna at the sublime tubercle. Okay, and so we start to put together the distal humerus and the proximal radius and the proximal ulna bone. And again, an additional anatomic structure where instabilities can manifest has to do where the head of the radius articulates with the lesser sigmoid notch of the proximal ulna. Well, the head of the radius is stabilized by the radial collateral and also the annular ligaments, which circumscribe or encircle the head of the radius bone. And then the radius bone simply rotates about a vertical axis within that articulation. So any injury or sprain of either the annular or radial collateral ligament can cause a destabilization here at the proximal radio-ulnar joint. Okay, now in addition, some other anatomic features of the elbow create bony buttresses or bony supports for the prevention of dislocation of any of the three elbow articulations. So first of all, there's a posterior buttress formed by the trochlea of the ulna and its overhanging anterior lip, which is the coronoid process. So the coronoid process here prevents any subluxation or dislocation in an anterior direction of the humerus over the ulna because of this large blockade, this large barrier, this large physical buttress to the subluxation or dislocation of the distal humerus over the ulna. So here we have an example of a dislocation of the distal humerus above and over the coronoid process of the ulna. So this represents, a severe mechanism of injury where the bony buttress has been violated, and then certainly there's also ligamentous and capsular damage as well. So the purpose of the coronoid process is to prevent this, but with severe mechanism of injury, such as on a fall on an outstretched hand, the bony buttress can fail, and this is an area where either subluxation or dislocation can occur. Also, there are buttresses on the anterior aspect of the elbow. The anterior and valgus force buttress is the radial head, which prevents anterior movements of either the ulna or the humerus on the radial head, as this area is highly stabilized by heavy ligamentous structures. And then for anterior and varus buttress, the coronoid process prevents both anterior slippage of the distal humerus anteriorly, and also because of the slopes of the sigmoid notches and the trochlear notches, prevents also suppresses varus forces that would otherwise cause instability or damage or injury to these articulations. So if this is the back of the right, if this is the anterior aspect of the right elbow, this is lateral, this is medial, and so the buttressing against varus forces is when the lower forearm is forced in a direction opposite the upper humerus bone, which would then cause an opening on the lateral aspect of the joint. That is prevented due to these joint surfaces being in such close proximity and with such high congruity, 180 degrees of congruity of the joint surfaces. It prevents the buttressing of the distal humerus and the proximal ulna in this direction, thereby offering stabilization in the lateral direction as well. Okay, so those are some of the bony buttresses and bony contributors to the stability of the elbow. Let's talk now about some of the ligamentous and soft tissue stabilizers of the elbow. And for soft tissue stabilizers, we're going to have both static and dynamic stabilizing structures. The static structures mostly being represented by the capsule and the periarticular ligaments. And then the dynamic stabilizers are largely comprised of muscles which cross the elbow joint, both the radio-ulnar joint, both the radiocapitellar joint, and also the ulno-humeral joint. Any joint that crosses one or more of those articulations through its muscular contractions and tendon crossings of the joint are going to contribute to the dynamic stabilization of that joint. Okay, so for static stabilizers, let's talk about the ligaments. The elbow is primarily stabilized by the medial and collateral ligaments, and we'll take a look at both of those. Both of the medial and collateral ligaments are thickenings of the joint capsule, and if you've ever seen this under dissection, you have the joint capsule, which is the innermost structure surrounding the joints and creating the inner synovial cavity. And then on the exterior surface of the joint capsule are these thickenings, these localized aggregations of increased, enlarged collagen bundles that run in these linear directions here. So the medial collateral ligament, which is what we're looking at here, the medial collateral ligament has three bundles. It has an anterior bundle, which is here. It has a posterior bundle, which is here. And then it has a transverse bundle, which is here. And the primary site of attachment, or the primary site of origin of the anterior and posterior, is right here up on the medial epicondyle. And then the primary site of attachment of both the anterior and the posterior is right here on what we referred to prior as the sublime tubercle on the posterolateral aspect of the proximal ulna. And then the transverse bundle simply reinforces both the anterior and posterior bundles of the medial collateral ligament. Now, on the other side of the elbow, the ulnar collateral ligament is a little bit more complex anatomically. This one is composed of four portions. The lateral ulnar collateral ligament, which is depicted here by this longitudinal bundle here. Again, all attaching here now on the lateral, originating from the lateral epicondyle here. The radial collateral ligament extends from the medial epicondyle down and around, cross to attach on the radial head. The annular ligament, which supports then the radial collateral ligament. And then finally, the accessory collateral ligament, again, which provides stability and support between the proximal ulna and the head of the radius. And then deep to all of those is the articular capsule itself, which surrounds all three of the elbow articulations. Okay, so this is providing stabilization to the lateral aspect of the elbow. Okay, so in addition to ligaments providing the static constraints of the elbow, muscles also provide the dynamic constraints, the most important of which is the anconeus muscle. The anconeus muscle, which is depicted right here, which has its origin at the lateral epicondyle of the humerus. Okay, and you can palpate this lateral epicondyle of the humerus, and has on its insertion is on the olecranon and the superior portion of the shaft of the olecranon. And its purpose, its muscle action, is to create extension at the elbow joint. So the anconeus muscle, because of its position here anatomically on the elbow, helps restrain varus forces, and then also posterolateral rotatory instability forces, which would tend to want to cause the ulna, the head of the ulna, to sublux or rotate posterolaterally in that direction in a semicircle. What would we say? Clockwise out in this direction. So that's restrained by the muscular action of the anconeus muscle. Also, the medial flexor muscles, those resist valgus forces that would tend to want to open the elbow medially. In contrast, the lateral extensor muscles resist varus forces or muscle forces which would try and open up the joint laterally. In addition to the medial flexor and lateral extensor muscles, any muscle that crosses the elbow, such as the brachialis, biceps brachii, the brachioradialis, such as the triceps muscles, which cross from the upper arm onto the olecranon process of the ulna, such as the supinators, such as the pronators, any muscles that cross any of the three articulations in the elbow have the potential and the capacity to provide stabilization during dynamic muscular contractions. They provide dynamic stabilization to the three articulations of the elbow joint. Okay, so let's talk about some physical examination maneuvers to assess for these instabilities at any of the articulations in the elbow. So we're going to be describing diagnostic maneuvers for the assessment of valgus instability, for the assessment of varus instability, and then for assessment of a couple of different types of rotatory instabilities. So remember that with valgus instability testing, we're testing the medial collateral ligament and especially the anterior band of fibers of the anterior medial collateral ligament. And maneuvers that we'll use for this assessment includes the valgus stress test, the milking maneuver, the modified milking maneuver, and the moving valgus stress test. And all of these maneuvers have as their purpose to impose or impart valgus stresses in the elbow. And if you picture the elbow outstretched in front of you, a valgus stress is a stress that tends to want to open the joint medially. So it's assessing for medial stability of the elbow articulation. That's where the medial collateral ligament is. And of the ligaments in the medial collateral ligament, it's the anterior band that particularly provides the most direct line of resistance against valgus stresses. Okay, so let's go over these physical examination maneuvers. With the valgus instability test, also known as the valgus stress test, and you should have this section in your report, in your physical examination, you should have this labeled the elbow stability evaluation, and then underneath that, your first test is the valgus instability test. So with the valgus instability test, you take the elbow and you place it in 20 to 30 degrees of flexion. With the elbow supinated, apply a valgus stress by applying pressure to the lateral distal humerus to drive it medially, and applying an opposing force to the distal forearm in a lateral direction, okay, away from the body. So you're imparting a valgus stress on the elbow, and you repeat 3 times, and you assess for laxity of that articulation, and you assess for reproduction of the examinee's symptoms. With the milking maneuver is simply another way to impart a valgus stress on the elbow, and the milking maneuver does it in slightly greater than 20 to 30 degrees of elbow flexion, such as the valgus stress test. With the milking maneuver, you take the elbow and you flex it to greater than 90 degrees. Greater than 90 degrees. So almost as high as the elbow will flex on its own, actively, through active contraction of the biceps muscle. And then simultaneously with the shoulder externally rotated, a valgus stress is then applied by pulling on the examinee's thumb in a lateral direction, while the opposite hand stabilizes the elbow joint and palpates the medial joint line for opening of the medial joint line, indicating a valgus instability. So you can try this on yourself. Simply flex your elbow to greater than 90 degrees, supinate the palm, externally rotate the shoulder, and pull on the thumb, and you can feel that imparts a fairly strong valgus stress on the medial aspect of the elbow. Now, a modification of the milking maneuver is simply referred to as the modified milking maneuver, and it simply places the shoulder in a slightly different position for the application of valgus stress. And you should use each one of these maneuvers, because whereas one maneuver might not reproduce the examinee's symptoms, another one of these maneuvers might well reproduce the examinee's symptoms. So with the modified milking maneuver, now the shoulder is adducted with the elbow in tight to the body, and the elbow flexed now only to 70 degrees, now again applying a valgus stress by pulling on the thumb in a lateral direction. Meanwhile, palpating the medial joint line for laxity and opening. And then finally, we have the moving valgus stress test. And with the moving valgus stress test, the examinee is in an upright position. The shoulder is in 90 degrees of abduction. with maximum shoulder external rotation and maximal elbow flexion. Now simply apply a valgus force to the elbow, attempting to open the elbow medially while extending the elbow through an arc of 60 degrees of range of motion between 90 degrees of flexion to only 30 degrees, or from maximal flexion of the elbow to only 30 degrees of flexion of the elbow. So with this maneuver, you're assessing for reproduction of the examinee's symptoms at various positions throughout the elbow range of motion. And certain portions of the range of motion may not reproduce the examinee's symptoms, whereas the examinee's symptoms may be reproduced in a different portion of the range of motion. So this one assesses for instability throughout the range of motion between elbow flexion and elbow extension. Okay, so those are some valgus instability tests. Let's now talk about some of the rotatory and varus instability examination maneuvers. Okay, so for the assessment of posterolateral rotatory instability, which tests the lateral collateral ligament, we're going to use the lateral pivot shift test, the posterolateral rotatory drawer test, the chair push-up test, the prone push-up test, and the tabletop relocation test. And then for the assessment of the opposite, which is the ventral posteromedial instability, we're going to use the gravity-assisted varus stress test. Okay, so let's talk about these different tests. Okay, so of those 5 tests, let's talk about 3 tests which are very easy to implement in the clinical setting. Okay, the first is entitled the chair push-up test. So with the chair push-up test, very simply, you have the examinee seated with the our elbows abducted away from the body and flexed to 90 degrees with the forearms in supination. The examinee then places his hands on the arm of a chair and pushes up as if to get out of the chair. This applies both an axial load and a valgus load when the elbow is in the supinated position. And so this also takes the examinee through many ranges of motion from elbow flexion to full elbow extension, and can identify or can reproduce examinee symptoms at any point throughout that range of motion. When this occurs, this is representative of posterolateral rotatory instability. The prone push-up test is similar, and it's going to involve extension at the elbow. The examinee starts in a push-up position with the elbows flexed to 90 degrees and the forearm in supination. Again, the examinee extends the elbow as in a push-up, causing extension at the elbow. But here, loads can be greater than with the chair push-up test. And if the radial head is unstable, if the radial head has a tendency toward subluxation or dislocation in examinees who have posterolateral rotary instability, this will cause apprehension and reproduction of pain and a feeling that the elbow is going to go out of place in an examinee who has bona fide instability syndrome. Then, as a confirmatory test, we have the tabletop relocation test, which involves the forearm in supination and the hand placed around the edge of a table, as if you were wrapping your hands around the long ends of a rectangular table while you're standing at the short end of the table. So you wrap your hands around the edges of the long edge of the tables on both sides, and you apply an axial load through the elbow while the elbow flexes, in other words, as if descending down into the bottom of a push-up position. And then this will reproduce the examinee's apprehension at approximately about 40 degrees of elbow flexion as load starts to be applied to the radial head. Well, in a positive report of apprehension in the lateral elbow, the examiner then applies pressure, anterior pressure, on the radial head, thus preventing subluxation of the radial head and preventing reproduction of the examinee's symptoms. Then you remove the thumb and confirm that the radial head again subluxes and again reproduces the examinee's apprehension, and then this is considered a positive tabletop relocation test, positive for posterolateral rotatory instability. Okay, so that's 3 tests for the assessment of posterolateral instability. Let's talk about posteromedial instability. Okay, so with posteromedial rotatory instability, we're again testing the lateral collateral ligament. The lateral collateral ligament, and I want you to reach out right below your lateral epicondyle and palpate around the area of the lateral collateral ligament. This is where the test forces and loading is going to assess this area right immediately below the lateral epicondyle. So the first is the gravity-assisted varus stress test. With this test, the arm is abducted to 90 degrees. The shoulder is now in neutral rotation, neither internal nor external rotation. And then the examinee simply flexes and extends the elbow, causing loading of the medial ulnohumeral joint. So imagine a bodybuilder posing his biceps muscles by flexing and extending the elbows with the shoulder in neutral rotation. So this causes loading of the medial ulnohumeral joint, and if it reproduces mechanical symptoms and or clicking or subluxation of the anteromedial facet of the coronoid process, this is indicative of instability to the lateral collateral ligament. Okay, so there's a couple of tests that you can include in your physical examination procedures for the elbow. Those aren't all the tests. We simply described 4 tests for the assessment of the lateral collateral ligament, and we described, I think it was also 4 tests for the assessment of the medial collateral ligament. So that should give you a pretty broad brush stroke through your physical examination, and is certainly much better than probably what you're doing now, which simply involves a varus and valgus stress test at most for your elbow examination cases. Okay, so this will significantly ramp up the robustness of your elbow examination. Now, as far as impairment ratings for the as far as the AMA guides are concerned, the AMA guides provide for permanent impairment rating values for persistent subluxation and dislocation of the elbow, and then also specifically for mediolateral instability, and then also what is referred to in the AMA guides as mediolateral deviation. Okay, so let's go into the descriptions of these and the permanent impairment values for these. Okay, so to understand how the AMA guides handles the permanent impairment values for these elbow instability syndromes, it's important to know that according to table 1618 of the AMA guides, the elbow comprises 70% of the upper extremity function. So considering the entire elbow, that comprises 70% of upper extremity function, with the ulnohumeral joint comprising 50% of upper extremity function, and the proximal radial ulnar articulation contributing 20% of upper extremity function. So what's going to happen is the AMA guides are going to provide for impairment values as a percentage of loss of upper extremity function, and then we would simply do a multiplication process taking that particular percentage times the 70% of the upper extremity function in order to arrive at a whole person impairment rating. And we'll go through a couple of examples as to how to do that. Okay, so again, let's talk about the definition of the first impairment that's described by the AMA guides. And this is impairment due to persistent joint subluxation or dislocation of the elbow. And this is something that you would largely derive through a combination of your history with the examinee and then also confirmed by the physical examination provocative maneuvers that we just described. So this impairment, persistent joint subluxation or dislocation, usually results in restricted motion. If there is no restricted motion, the values shown in table 1622 right here are multiplied by the relative value of the joint. So we had the total elbow at 70%, we had the ulnohumeral joint at 50%, and the proximal radial ulnar joint at 20%. So each of these joint impairments would be multiplied by the 70% in order to get an upper extremity impairment, which would then be converted to a whole person impairment. So with a mild severity of subluxation or dislocation, this is a joint that can be completely reduced manually. This qualifies as a 20% times a 70%, which equals 14% upper extremity impairment. This would then be converted into a whole person impairment. With a moderate severity of joint subluxation or dislocation, the articulation cannot be completely reduced manually and requires either an outside force or perhaps sedation in order for the joint to be realigned properly. This qualifies as a 40 times 70% for total elbow, 70%, which is a doubling at 28% upper extremity impairment. And then the severe is an elbow articulation that cannot be reduced and requires emergency medical services. This is 60% times 70% for the total elbow is 42% upper extremity impairment. This would then be converted into a whole person impairment rating. So that's how persistent joint subluxation or dislocation is handled. With elbow passive mediolateral instability, again, we're going to get a percentage of impairment of the elbow joint, and we're going to multiply it by the ultimate value of that joint to arrive at an upper extremity impairment value, which would then be converted into a whole person impairment value. So the guides tell us that mediolateral laxity or instability is tested by passive manipulation in various positions of flexion and extension. So this would be the moving valgus stress test, and then also the chair push-up tests and the tabletop relocation tests, all assess in various positions of flexion and extension. And it obtains the maximum medial lateral joint angulation is measured in degrees in order to measure the mediolateral instability. The severity of the mediolateral joint instability is rated according to the excess number of angulation degrees compared to the opposite normal side. So on the opposite normal side, you would need to obtain the Q or carrying angle to determine a baseline normal for the opposite unaffected extremity, and then by measuring the excess number of degrees on the affected elbow extremity. If both sides are involved, a comparison to accepted normal average values is made. The percentage of impairment is then multiplied by the relative value of the joint, which is listed here, to determine the joint impairment. Okay, so let's go through a couple of these impairments. When the excessive deviation degrees compared to the normal, either the opposite uninvolved upper extremity or to normal population normals when both upper extremities are involved. If the excessive degrees is less than 10 degrees, which is going to be most of your examinees, that qualifies for a 20% joint impairment. Moderate at 10 to 20 degrees qualifies for a 40% joint impairment. And then greater than 20 degrees of angulation is basically a flail or flail elbow. This qualifies for 60% joint impairment. So again, that was 14% upper extremity, 28% upper extremity, and 42% upper extremity impairment for each of these severity grades of mediolateral joint instability. And then also we have medial or lateral deviation, and this describes the misalignment of the normal anatomic alignment of the humerus bone with the radius annulta bone at the elbow, where the angulation is measured again here at the elbow. So this is measured now in maximum active extension of the elbow. The severity of lateral deviation is rated according to the excess number of angulation degrees compared to the opposite side. So this would be an example of great angulation. This would be an example of a modest angulation. Both of these being valgus angulations. This would be an example of a varus angulation. So it's important to get the examinee's normal Q or carrying angle in order to measure the excess angulation. Okay, so normal valgus carrying angle for males is approximately 5 to 10 degrees, 10 to 15 degrees for females, and in both, because of the shape of the trochlea and the trochlear groove, this diminishes with elbow flexion such that the carrying angle can actually disappear down to 0. So with a mild angulation, less than 20 degrees, we have 10% joint impairment, which is 7% upper extremity impairment. Moderate angulation, 20 to 30 degrees, is a 14% upper extremity impairment. And a severe angulation greater than 30 degrees represents a 21% upper extremity impairment, or a 30% elbow impairment. Okay, so doctors, I hope that's an interesting review for you on the anatomy, physical examination, and impairments for the elbow instability syndromes. And it's interesting because many doctors don't do an assessment of elbow instability. They'll do some elbow range of motion. They'll do some tests perhaps for medial epicondylitis. They'll do some tests for lateral epicondylitis. They might do a cubital tunnel examination for ulnar nerve entrapment. And they examine the elbow, many QMEs that is, as if they're doing an elbow assessment in their clinical practice. Well, our medical legal practice in the workers' compensation system is a little bit different. And in our medical legal practice, we want to specifically target our physical examination procedures to the assessment of impairments and instability of the elbow, whether it be persistent subluxation or dislocation, posteromedial or medial instability, or mediolateral deviation. Those three instabilities, our physical examination needs to assess for each of those. So we need to have a section in our physical exam where we assess for persistent subluxation or dislocation, where we assess for mediolateral instability, where we assess the angulation for mediolateral deviation. So you should have specific findings in every single one of your elbow examination cases to show the parties whether or not the examinee has impairment due to these elbow instabilities, or on the contrary, whether the examinee does not qualify for these impairment ratings. So examine for the impairments, and in the elbow, one of the impairments is elbow instability. And it's interesting, with the most severe of these elbow instability ratings, The ratings can be high as, what did we say, 48% upper extremity impairment. 48% upper extremity impairment. So 48% is approximately what? 25% whole person impairment. So the whole person impairment ratings for these elbow instability conditions is significant. Significant. Anywhere between 0 and 25% whole person impairment, approximately. Okay? So you have examinees who could qualify for these impairment ratings if you simply target your physical examination procedures to determine the presence or the absence of these impairments. Okay? So we reviewed the anatomy of the elbow, including the medial collateral ligament, the lateral collateral ligament. We talk about the bony, static, and dynamic structures that resist various varus forces, various valgus forces, and various rotatory forces. And we describe some physical examination maneuvers to assess for all of the structures that would otherwise resist those forces. Structures that, when injured, when damaged, when suffer permanent loss of function, do qualify for substantial impairment ratings under the AMA guides. So I encourage you to become a master in the elbow instability assessment, because you will only discover these true conditions when they're present if you specifically examine for them. Okay? So I hope that helps you. Now in our next session, we're going to go into several concepts associated with wrist injury and instability of the carpus. So we're going to talk about carpal instability, and this is a fascinating section that the AMA guides go into in great detail, and I have a fascinating anatomic and permanent impairment review for you. So for now, this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on today's session, and I look forward to being with you on our very next session on carpal instability as well. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.